Good morning, everyone. I'm excited to share my 6 months progress on my PhD thesis titled Optimizing Techniques and Outcomes in Implant-Based Breast Reconstruction. My name is Dóra Fedorcsák, and I'm a 5th-year medical student and the 1st-year MD PhD student at the Department of Surgery, Transplantation, and Gastroenterology. My supervisor is Zoltán Klárik, and my SMS is Lőrinc Frivalczky. Our vision is to provide the best possible surgical care to breast cancer patients, and our mission is to determine which adjunctive materials can help achieve a better surgical and aesthetic outcome. During the past 6 months, we have started working on 2 projects, and I would like to first introduce the first project, which is titled Investigating the Effect of Adjunctive Materials on Implant-Based Breast Reconstruction Outcomes in Irradiated Patients. As mentioned before, in 2022, over 2 million patients were affected by breast cancer worldwide, and 20% of these patients undergo breast reconstruction after their mastectomies. As you can see from this graph, more than half of these surgeries are implant-based. Also, over 50% of these patients receive radiotherapy as a part of their oncological breast cancer treatment. This poses an increased risk of capsular contracture, implant loss, and infection. Reconstruction failure can be up to almost 40% in irradiated patients compared to only 8% in non-irradiated patients. In this complicated patient group who have compromised tissues due to radiation, the use of adjunctive materials like synthetic or biological meshes can help achieve a better surgical outcome and less complications by helping tissue regeneration and also relieving the stress from these tissues. Our aim is to determine which material is most useful in patients who received radiotherapy. Our clinical question is, which adjunctive material can provide the most satisfactory outcome in implant-based breast reconstruction? We are using the PICO framework for the first project with the populations of patients receiving implant reconstructions and radiotherapy, and we're comparing the use of synthetic mesh to biologic mesh in the supporting of these implant reconstructions. We're looking at surgical outcomes such as implant loss, capsular contracture, or infection. We hypothesize that the use of these materials can help these implant reconstructions achieve a better surgical outcome and quality of life. The clinical implication would be implementing the use of these biological or synthetic meshes into breast cancer surgery. We have conducted a search in 3 databases, with the first domain focusing on the implant reconstructions and the second domain focusing on biological or synthetic meshes. During our selection, we have arrived to a total of 47 articles, and through citation chasing, we were able to add 5 more. Allow me to introduce our results so far. The first one being total complications. We are looking at observational single-arm studies here, so we're looking at the proportion of total complications, meaning the rate of patients who experienced at least one postoperative complication. We can see here the 2 subgroups, the biologic and the synthetic mesh group. The heterogeneity in the biological group was quite high, which can be due to patient confounding factors or the differences in surgical techniques. We can see a pool proportion rate of around 30% in both of these groups, which meaning that 1/3 of these patients experienced at least one postoperative complication. The test for subgroup differences was not statistically significant in this case. Moving on to the second plot of implant loss, which means reconstructive failure, we can see pool proportion rates in the biology group of 16% and 8% in the synthetic group. We also explored the rates of capsular contracture, which is one of the most common complications in implant reconstruction, which can cause pain, discomfort, and also the need for an additional revision surgery. The pooled rates of capsular contracture in the biology group was 10%, and in the synthetic group showed to be 17%. The strengths of these results is that we were able to provide comprehensive data poolings because of the large group of studies in the biology group. We were able to show clearly defined subgroups, and the limitations, though, on the other hand, is that these are single-arm studies. They have high heterogeneity in the biology group, and we have limited data in the synthetic group due to less studies reported. In conclusion, for now, both meshes seem to have low complication rates, but we were not able to show statistical significance in our results so far. The heterogeneity and the limitation of our studies are an implication for further research. Larger high-quality studies would be needed, also stratified analysis to identify subgroups, and investigating the sources of heterogeneity would be also quite useful. The implication for practice of this study would be to have the informed decision-making of surgeons choosing surgical technique, while also encouraging a more individualized approach considering patient and surgical factors as well. For now, with the first project, we are working still on the risk of bias, and we have some of the figures and tables. Moving on to the second topic, we would like to investigate the efficacy and safety of utilizing negative pressure wound therapy in prosthetic breast reconstruction. In 2022, more than 150,000 breast reconstructive procedures were performed in the US, of which almost 80% were implant-based. The infection rates of these surgeries can range from anywhere to 2 to 25%, which can not only lead to implant removal, meaning the reconstruction failure, it can also cause delays in the administration of radiation and chemotherapy. Utilizing a negative pressure wound therapy device can assist in the reduction of edema, can help with increased dermal perfusion and granulation tissue formation, and most importantly, reducing bacterial colonization. Utilizing negative pressure wound therapy in the case of already infected implants can have as high success rates as 80%, and the time to the final reconstruction can be lowered from 220 days to only 70 days, some studies show. As we can see from this graph, even though the beginning costs of utilizing negative pressure wound therapy can be way higher, with time regarding the benefits of this therapy, we can actually decrease the costs of the healing of these patients with reduced outpatient clinic visits and less complications. Our aim is to find the most effective technique to minimize complications in implant-based breast reconstructions. Our clinical question is, can the use of this negative pressure wound therapy device help achieve lower infection rates and better salvage rates in the case of infected implants? We're again using the PICO framework of patients undergoing implant reconstruction. We're comparing the use of negative pressure wound therapy to standard wound care, and we're looking at postoperative complications and salvage success rates. We hypothesize that implementing this device into everyday breast reconstruction practice can help achieve accelerated wound healing and better salvage success rates. Our key articles so far are reporting similar outcomes and all have a follow-up of at least 1 year. We have done the preliminary search, although this project is still in the beginning phases. To summarize, in the past 6 months, we have started working on 2 projects. The first project focusing on the use of adjunctive materials in complicated populations such as irradiated patients in implant reconstructions. And the second project focusing on the utilization of negative pressure wound therapy in prosthetic breast reconstruction. I would like to end my presentation with a quote, "Live as if you were to die tomorrow and learn as if you were to live forever," by Mahatma Gandhi. Thank you for your kind attention.
So congratulations. So regarding your first project about the population, so is it primary reconstruction or delayed reconstruction?
Good question. The studies, we have included studies of both kinds. But these are the first, it is primary in a way that there were no reconstructions before, but also the delayed reconstruction, meaning that they wait a specific amount of time after mastectomy, then yes, also those kind of studies were included as well. So it's a bit mixed.
Okay, thank you. And just a tip, so you have NPWT and steroid and combine these two, and maybe this is the best treatment option for the future. Maybe,
yes.
Thank you.
We just discussed it with the board member. Thank you for your talk, and we would like to congratulate. How many times did you practice this presentation? Did you practice it at home? Because this program is not only about making science, but improving in how you interpret yourself in front of an audience, how you can discuss. So I think I would say 50% is science, and then you can benefit after the 3 or 4 years of the program a tremendous amount of soft skills. And I would like to highlight your presentation because obviously you had great English, which everyone has a baseline, but you can improve, all of you. And we saw that you were probably practicing it, so the pace and the fluency in the presentation was really good, so congrats again.